I presented an overview of the results of the trials in Europe. You know that we had some small randomized trials, one in the north of Europe, in Netherlands and Belgium, the other in Denmark, and different kind of trials in Italy. But unluckily, the very small trials didn't reach any positive result in terms of mortality reduction. So in the overall group who underwent low-dose CT, the mortality was similar to the control group. But the limits of these screening trials were mainly the small sample size, so they were underpowered. On the contrary, low-dose CT, the national lung screening trial with the low-dose CT in US, which had a large population, 50,000 individuals randomized, had positive results in terms of reduction of mortality, 20% reduction. And this is also underestimated because it was designed to reach 20%, then it has been stopped. So if the follow-up would have been longer and low-dose CT more than 3 rounds, probably the effect would be more extended, like 50% mortality reduction. This is what we imagine can be the objective. And so we will have around 350,000 deaths for lung cancer in Europe. This is our estimation for annual deaths, all for lung cancer. So we think that development of a large-scale screening program is an urgent need. And we think that the rate of benign disease at surgery, the false positivity rate, is reduced if you use a validated diagnostic algorithm. And you also can spare costs and save money if you use the risk models to select the population and define the screening interval. This is also a paper that has been presented in Denver from the Pan-Canadian group, in which they used this risk model to start and to develop a screening program, and the cost-effectiveness analysis was very positive, and they calculate around 9,000 euros for each quality of life adjusted year saved. So much lower compared to what has been calculated in US around the NLST study. So the conclusion were that screening is feasible and safe and reduce mortality, so should be implemented in Europe.